And now I would like to present to you Andreas Sönnichsen, who is an Austrian equip member and a professor of general practice in Salzburg in Austria, and is also working with a large EU project on patient safety, the Linnaeus project, and who's going to give us our morning lecture. Thank you. Thank you.
Thank you, Tina, for this introduction. Dear Tina, dear colleagues, and thank you for the opportunity to give this presentation on patient safety in family medicine. If we hear the word patient safety, the words patient safety, the first thing we think of is the classical problem: the wrong leg amputated, wrong kidney removed, and spectacular things like that. And we don't really think of primary care. And I just talked to another equip member yesterday, and when we were discussing whether patient safety should be a part of equip and a part of the name, and he said, well, patient safety in primary care, it's not really that much of an issue. And I think he's wrong. And we'll try to show you why, and I will try to show you what needs to be done. To begin with, a few remarks about the Linnaeus project. It's a EU 7th framework project with, I think, now 10 partners from all over Europe. And we are focusing on patient safety in primary care. There have been several EU projects on patient safety in secondary care, and they are taking care of the spectacular cases, like Sympathy and UNET Pass, but there never has been something that has been really focusing on primary care. So this is actually something new, and we are doing quite a bit of interesting work there. And some of the things that we're doing there I will present to you now. You heard this already yesterday. The patient-doctor contacts, and it's very low in Sweden, and it's very high in Denmark, and Austria is somewhere in the middle, where I'm from. And it doesn't sound all that much, 7 doctor-patient contacts per year, but if you multiply it with the population, you get quite a large number. And if you take a look at why patients come to the doctor, I've presented you some data from 1989, which are old data, and some quite new data from my own practice. We analyzed 500 consecutive patients, and still the majority of these people, of these patients, come to our practice because of symptoms, because of complaints. And even though quite a few of these people are probably patients that do have chronic diseases as well, but still these people come with symptoms. And with symptoms, we need to make decisions. And decisions always pose a threat to patient safety. Looking at this, in Austria, we have about 55 million patient-doctor contacts per year. And that means that if we take the percentage of between 50 and 60% patients coming because of symptoms, that means that about 32 million diagnostic decisions need to be taken, whether the symptoms the patient comes with are serious, are sign of a serious disease, or are just complaints that will go away by themselves. But this decision needs to be made in every single case. And the result of the decisions and the result of taking care of chronic care patients with chronic diseases, is that in Austria we have about 80 million prescriptions per year. So with this in mind, there's a lot that can happen. And The two main topics are we can make a wrong diagnosis, we can make a wrong decision on the symptoms the patient presents with, and we can make wrong decisions on treatment. Let's talk about diagnostics first. The problem of diagnostics in primary care is the problem of low prevalence and uncertainty. And we can have patient harm in both ways. We can have patient harm by missing a diagnosis, but we can also have a lot of harm by overdiagnosis. Let's take a look at a case. A 65-year-old female patient, she complains of intermittent chest pain and a sensation of pressure in the chest. The symptoms started about 2 months ago. At times, she feels palpitations and she gets out of breath quickly when climbing stairs. Her son had just told her that he was getting divorced, and she's very worried about him. Her father had a myocardial infarction with 55. She believes, "Doctor, I think something's wrong with my heart." She never smoked, and she has always been healthy. This is the typical patient we deal with every day, right? Isn't it? It could be, but maybe not. Well, with this psychological stuff in the background, we tend to think, well, maybe it's just the stress. Let's take a look at her closer. She weighs 78 kilos, is 160 centimeters high, which is a BMI of 30. Blood pressure with 150 to 90, slightly elevated. This is an office blood pressure. We don't know yet whether it's a real blood pressure or maybe it's just a temporary thing because of the problem with her son. Her cholesterol, 225. We don't really make much of that, don't we? HDL cholesterol, 64. That's pretty good. Fasting glucose. She doesn't seem to have diabetes. So what's the risk of this patient? We have a nice tool in Germany and Austria, which is Ariba, which we developed in Marburg. And with this tool, we can show ourselves and to the patients what's actually your risk to have coronary heart disease or to get coronary heart disease, to have a cardiovascular event within the next 10 years. And if we enter the data, and this is Framingham-based, but adapted to Central European conditions. And if we enter the data of this patient in Ariba, we get a risk of about 8% to have a cardiovascular event in the next 10 years. But what does that mean? That means, well, the risk is not very high, but it's not zero, right? So this patient may very well develop or already have coronary heart disease. So how do we find out? If we take a look at the literature about symptoms and what is the diagnostic value of symptoms, we find that, for example, sensation, I think you can read it, I don't have to point. Sensation of pressure in the chest is a symptom with a sensitivity of 66% and specificity of 48% in the detection of coronary heart disease. Now, this is a symptom this patient has. So what does this, what comes about this information? We know from other studies that the prevalence of coronary heart disease in an unselected patient collection of a GP is about 8% that present with chest pain. Now, it's only a matter of mathematics to find out that with 53 patients with sensation of pressure will actually have the disease. 27 will have the disease, they have chest pain, but they don't have this pressure feeling. And there are of course, in primary care, if we have a prevalence of 8%, there are 920 patients out of 1,000 that don't have coronary heart disease. But quite a few of those do have pressure. And that adds up to a false positive rate of 478. And this, again, means the positive predictive value of this particular symptom is 10%. Now, you see what is the gain from this, from taking a look at this particular symptom. It's only 2%, because we knew before the risk of this patient is 8% to have a coronary heart disease. And now, with the symptom of pressure present, we know the risk is 10%. So we didn't really gain all that much information from that single symptom. That's why I tell my students in second year, you have to take a very thorough history and get all the information you can find, and then that adds up to increasing your positive predictive value regarding the disease you're looking for. There's another possibility. We did a diagnostic study in Marburg on chest pain, and we investigated about 1,200 patients, and we came up with the Marburg score. And the Marburg score is quite good in the prediction of coronary heart disease if the patient has a high score. Now let's take a look at this particular patient. She's not over 65. She's still 64, so that's 0 points. No, she doesn't have vascular disease, no points. Pain doesn't get worse during exercise, no points. The pain is not reproducible by palpation. I checked that, and it's 1 point she gets. And the patient assumes the pain is of cardiac origin, so that's another point. So she gets 2 points in this score, and with 2 points, the score has a validated sensitivity of 98% and a specificity of 40%. Now, the sensitivity is pretty good, but does it really help us? Yeah, it helps us not to overlook anybody. But the problem, again, is the specificity. And now, if we take the information we already have and we raise our prevalence to 10%, then we get this picture. And of the 100 patients that have a positive Marburg score, a score of 2 or above, 98 we will find with this diagnostic tool. But of the patients that don't have the disease, 468 of the 900 will have a positive score. And what does this to our predictive value? Well, it goes up to 17.3%. That's not so bad, isn't it? It's more than the 2% we got before. So by doing this, we slowly increase our positive predictive value. But still, 17%, what's that? I mean, what do we do with this patient?